but X-ray is valuable to further evaluate the details of fractures, which may help us to treat the patient. And routinely we use anterior and posterior and lateral radiographs to judge the degree and the extent of the fractures, and we typically include one of the adjacent joints. If necessary, another limb could also be imaged for control. In this case, particularly in child, the bone are not fully developed, so sometimes it's hard to judge if there is a fracture line or not. In this case, you just take an X-ray for the normal limb for control. There will be a lot of complications follow the fracture, particularly for the complicated compound fracture. And we artificially divided the fracture, the complications into two groups. The early complication and the late complications of fracture. The early complication includes shock, as I have talked, and fat embolism syndrome. That means the fat in the bone marrow was released due to the broken of the bone, which suddenly entered the blood flow and accumulated somewhere, for example in the lung, causing serious pulmonary problems. And other complications may be visceral injuries, according that in the lung, in the liver, in the spleen, and urinary injury. This is pretty common followed a pelvic fracture. Even now, we have 2 patients of this urinary injury. It may be vascular injury, which is more severe, more serious than simple fracture, because this vascular injury will cause the death of the distal limb. And there are spinal cord injury. This is really a sad complication. It's not so common, but when it happens, it's disaster for the patient. And it happens follows the cervical and thoracic spine fractures. Peripheral nerve injuries may be caused directly by the physical impact, or may be caused injured by the sharpened fractured bone. Osteophyseal compartment syndrome, as we know, the muscles are located within the compartment. So when there's a fracture, there's hemorrhage, and the muscles got swollen serious. So the pressure in the compartment increased. When the pressure is high enough, they will compress the arteries and the veins of the muscles, resulting in the ischemia of this muscle. And if you didn't find this in time, that will lead to the death of the muscle, loss of function for the limb. Late complications include hypostatic pneumonia. This is really common for old men or women. When they got a fracture, they have to lie down in the bed for a couple of months, and we're followed by the pneumonia. This one is decubitus, which is also called pressure sore, which is most common at the surface of sacrum. Also more common in the older man. And another one is deep vein thrombosis. When you have a fracture, then all the muscles stop working, and you have to lie down in the bed, and the blood flow is slowed to some degree. And gradually, the thrombosis forms. Infection is easy to understand, particularly for the open fracture, and the fracture site was contaminated, and infection sometimes is not avoidable. And myositis ossificans, which means the muscle was ossified to some degree, so the function got lost. Traumatic arthritis, this is a common complication follows the intra-articular fractures, ankylosing, which is more common in the elbow fracture, and the function of the elbow lost, cannot extend or flex, the bone atrophy, and avascular bone necrosis. For example, the femoral neck fracture will lead to the necrosis of the femoral head. So in this case, you need an artificial joint replacement. Ischemia contraction, this is usually followed the compartment syndrome, specifically referred to the muscle dysfunction due to the ischemia. So let's transfer another topic, the healing of fracture. Actually, there is a long way for the broken bone to heal, and we artificially divide the healing of the fracture into 3 phases. The first one is called the phase of hematoma, which actually started immediately after the fracture. And in this case, this phase will extend from a couple of days to 3 or 4 weeks. There are hematoma here, there are the blood swelling tissues here, and gradually the white blood cell will accumulate here, and the osteoblast will swing towards this injury site. The second phase is called callus formation. At this stage, there are fibrils growing here, and the primary callus was formed, and osteoblasts start working. There are a little bit of calcification forming around the hematoma, but this primary callus is not mature, cannot undergo serious mechanical load. This phase will last from 4 weeks to 3 months. The last stage is called callus consolidation and remodeling, which means the immature callus gradually deposit with calcification, calcium and calcification. So the callus got remodeled, got solid, connect the bones together. At this stage, the patient is almost healed, can do some walking or something else. So as a physician, we have to know when is the bone fracture healed. You have to tell your patient. There are a couple of standards available here for you to refer. The first one is the absence of local tenderness and longitudinal percussion. Simply, you can do physical examination by doing the percussion at the fracture site. There should be no pain at all. Otherwise, that means the fracture healing is just on the way. And it should be without abnormal movement. For example, there's no joint, there should be no movement there. And the vacuole fracture line, this was a finding from the X-ray images. If the fracture line is clear, that means the fracture is still there, there is still fracture. And the injured limb functions well without external fixation such as plaster. This is also important. There are a lot of factors that may affect the process of bone healing. For example, general condition, which means the age, for example, is critical factors affecting the bone healing. If the patient is just a kid, so the fracture will be quickly get healed, while in old patients will take a much longer time for the bone to heal. And the health status of the patient, a lot of general disorders may delay bone healing, for example, diabetes or leukemia or whatever. Other local factors are discussed as following. The type of fractures. This is a leading factor of the bone healing. If it's a confound fracture, if there is a complex open fracture and soft tissues are severely injured, then for sure this bone healing will be delayed, at least not as fast as the simple fractures. Vascularity of fracture tissue, as I've mentioned, the soft tissue blood supply is critical for the bone healing. If the soft tissue itself got a serious injury, then the bone blood supply will decrease significantly. Degree of soft tissue injury and the insertion of soft tissues to the bone fragments. That means between two ends of the fracture there is a piece of soft tissue which separates the bone fractures. This will block the growing of the bone. And another factor is infection, which is even more serious than any of them. If a bone site, fracture site got infected, it will take a long time for us to treat the patient. A third group of factors is called treatment approaches. There are a lot of options for us to treat the patient. So, for example, there are manipulative reductions. Sometimes the patient do not want surgery, so we just reduce the fractured by manipulative maneuvers. But for sometimes it's not easy, so we do repeat the maneuver again and again, try to obtain anatomic reduction. And this maneuver actually will seriously injure the surrounding soft tissues. And this is not a good thing for the bone healing. Over surgical separation of soft tissues. For example, in surgery we do not have good exposure, so we separate the soft tissue widely, and these actually damage the blood supply around the fracture. And the degree of soft tissue injury, I've mentioned this again and again. Soft tissue injury is really critical for the bone healing. The bone defect, in some cases, for example, open fracture, some piece of bone is missed, probably on the scene of the accident. Then there's a bone defect. For sure, there will be scar or soft tissue grow into the defect, which may delay the healing. Over distraction, this is not so common now. In the old age, when people got a femur fracture, they use skeletal traction, and the weight is not so well controlled, so we have this kind of over distraction. There's a wide space between two fracture ends. Unreliable fixation. Yes, a lot of cases the bone healing was delayed because of this internal or external fixation is not reliable enough. We physicians think it's strong enough, but actually they are local loosening. Inappropriate rehabilitation, that's hardly seen nowadays. In my career, I have such a kind of case. The patient just want to walk while the bone actually is not healed, and in that case, the bone will be delayed. Bone healing will be delayed. So another topic is initial management of the fracture. If you physicians, MD students or graduates happening on the scene of the car accident or something like that, you identify the fractured patients, what should you do? For sure, the most important thing is to save their life. So first aid treatment is very important here. First thing is airway. Make sure that the airway is clear, the patient can breathe. And you have a brief and important clinical assessment. For example, you touch the pulses and the vertical artery pulse. See if the general condition of the patient is okay. And if you find there is no pulse, the patient got pulseless, then resuscitation is necessary. As you have trained on this area, I want to go into details. Another point is to mention is that do not over move the limb. Sometimes in order to save life, you probably turn these patients here and there. That's not good for the fractures. So minimally move the limb. We will further talk about this. This should control any external hemorrhage. So if the patient got an open wound, probably he is bleeding, and you need to cover the wound with a clean dressing, using your own coat or from the coat of the patient, whatever you can find which is clean. Just cover it, and hemostasis using pressure, just compress on the wound, and the blood will be controlled. And please do not reduce in open fractures. In some serious cases, if bones are exposed and we frighten a lot of people, they try to reduce the fractured bone. This is not necessary, and we treat another physician thinks this probably is a closed fracture. A second step is appropriate immobilization. This is very important. The aim of immobilization is to prevent further injury, reduce pain, and facilitate transportation. Excuse me. And you can immobilize the limb with the best things you can find around. For example, the splint, stick, board, or sometimes even another healthy leg. This is a splint we use, very popular in China, used to immobilize the forearm. In this case, there's nothing to fix, just bind the two legs together to immobilize. And do not reduce the open fracture, remember this. And then everything is done, the patient is stable, and you immobilize the injured limb. The next step is transport the patient to a hospital as soon as possible. Okay, now the patient arrived in our hospital. We need to treat the patient. And there are three basic principles of fracture treatment. One is called reduction, immobilization, and preservation of function. It's really simple, only 3 points, 3 words, but it's critical for the patient. A lot of cases we cannot do something, preservation, immobilization fully, resulting in a disability of the patient. So here we have 2 standards of reduction. When you reduce the fractured limb, when is it okay? So we have to check it out using the standards here. The first one is called anatomic reduction, which means that we reduced all the displacements and obtained an anatomical alignment of the fractured bone. This is perfect. Everyone wants this, but in some cases it's just impossible. And we have another standard for this functional reduction, which means the limb function won't be affected, although an anatomical reduction was not obtained. In this case, there are a little bit displacement, but if the bone got healed, they won't affect the functions of the limb. That's also fine. It's not recommended to obtain an anatomical reduction by multiple manipulative reduction. As I have mentioned, these multiple things will increase the injury of the surrounding soft tissue. And here is the standards of functional reduction. So when you think we obtained a functional reduction, first the rotation distraction should be fully or completely corrected, because these are really critical in the extremity functions. And for the adults, the shortened by 1 centimeter should be at the lower extremity should be corrected. Otherwise, the patient will be got discrepant, which means will have a limp gait. Lateral angulation replacement, displacement should be corrected. And for the shaft or long bone, at least 1/3 of the bone axial area should be touching each other, should be contacted. For epiphyseal fracture, for example, in the children, this area should more than 3/3. For kids, shortening of leg no more than 2 centimeters, because the children have better remodeling ability to correct the discrepancy of the lower extremities. There are a number of ways used clinical to reduce the fractures. For example, closed manipulation and mechanical traction with or without manipulation, and open operation. This means surgery, manipulative reduction. First, we need pain control and relax related muscles and take the right direction, match the distal bone end to the proximal end, and slightly distraction. And use the soft tissue hinge to reduce fracture. Here is a typical case of Colles fracture or distal fracture of these radius. Here we use kind of soft tissue hinge to reduce the bone and fix it with a plaster here. I won't go into details. It's pretty complex for you guys. Open reduction, there are serious indications. For example, if you failed to reduce the bone or obtain a functional reduction using manipulative reduction, then you have to use surgery or open reduction to achieve the reduction. For example, intra-articular fracture failed to obtain a satisfactory alignment. In this case, probably serious arthritis will follow quickly. So if we have a chance, we try to operate on this patient to repair the displaced bone and reach at least a functional reduction. And fractures are with vascular nerve injury. In this case, it's serious. This vascular injury is even more important than the fractures itself, because it will lead to the death of a limb, a leg, or an arm. If the patient got multiple fractures, it's really hard to treat using the manipulative reduction. So in this case, we try to operate on the patient using internal fixation, then the patient can move early and will achieve better outcomes. But open reduction means surgery. There are a couple of advantages and disadvantages. For example, the open reduction may obtain anatomic reduction because the fracture was opened. The surgeon can carefully repair the bones to the original status. And we may perform internal fixation. This is second treatment principle of fracture. And early rehabilitation with internal fixation, we can have the patient exercise early and prevent fracture complications. However, there are a lot of disadvantages also. You further damage the blood supply. All surgery will damage the blood supply of the fracture, and non-union or delayed bone healing is not so rare in clinic. Further injuries of the tissue will lead to expose the patient to the risk of infection, and failure of internal fixation may need to remove the instrumentation for a second surgery. It's a common thing. Methods of immobilization. These stuffs are used for the non-operative immobilization. For example, splint, plaster, traction, brace, or orthosis. And this side is some stuffs used for the open immobilization. For example, the internal fixation, we use plate, screw, intramedullary nail, and Kirchner wire. So when we should treat the patient conservatively, when should we use surgery to treat the patient? We have a lot of indications. For example, for the conservative treatment, particularly in children, maybe we do not need surgery. We simply use conservative ways, and the patient have relatively better remodeling ability. And fracture without displacement, that means it's a simple fracture. We probably can immobilize the limb with a plaster or splinter and also achieve perfect clinical outcomes. Severe osteoporosis, in this case, probably you cannot screw a plate as the bone quality is really worried. And in some cases, the patient cannot use internal fixation. We have to use some other things like plaster or traction sometimes. With surgery contraindication, some very old patients got the lung, for example, pulmonary infection or something, high pressure, very serious coronary diseases. In this case, they cannot take the anesthesia, so we have to use the conservative treatment. There are a lot of equipment here for the completive immobilization. For example, this case is splint. It's really popular in China here, as you see here, used to immobilize the forearm and immobilize the leg. And it's used for the close fracture of the long bones. So it's very cheap, and the fixation is reliable. When necessary, we can retire this splint again. That means this immobilization is adjustable. This plaster probably is the most traditional way of immobilization, and the advantages is that we can shape the plaster into the leg shape, which is perfect, and the fixation is, the immobilization is reliable, but there are a couple of disadvantages. For example, it's not elastic. When you did this plaster, you cannot change it. If you want, then you have to make another one. Also immobilize the joint here, as you may see here. Immobilize the ankle joint, knee joint here. Immobilize this ankle. Perhaps the fracture actually is here, and it's not adjustable. This is traction. There are two types of tractions. One is skin traction, another is skeletal traction. This is skin traction, which is not so commonly used in our clinical, and this is not reliable. Through this stuff, there is weight tracting the limbs like this, and commonly what counts down is not the fractured bone, but just this elastic bandage. Almost only used in leg, and pretty always used for temporary immobilization. For short time maintenance, for example, after surgery, you got artificial joint replacement, and then we use this for short time maintenance. This is skeletal traction, which we use a pin punch through the tibia or femur. Then we have the weight function here. And this skeletal traction we can use for a long time. It helps to reduce the fractured bone, but only used for the femur, tibia, and humerus. Here is the orthoses. A lot of them are used daily in our orthopedic ward. This is for the ankle, this is for the cervical spine, ankle, wrist, and these are you can use for incomplete fractures or fractures without serious displacement, and used for soft tissue injury. And these are external fixator here, a number of them, and it's used for degree 3 open fractures when the soft tissue is open